All right, this is Chapter 26, Trauma Overview, National Standard Competencies. Trauma applies to fundamental knowledge to provide basic and selected advanced emergency care and transportation based on the assessment findings for an acutely injured patient. For your overview, we're going to cover patho, assessment, and management of the trauma patient, trauma scoring, rapid transport and destination issues, transport mode. Multi-system trauma, the recognition and management of multi-system trauma, pathophysiology assessment and management of multi-system trauma, blast injuries. According to the U.S. Centers for Disease Control and Prevention, unintentional injury is the primary cause of death and disability in people between ages 1 and 44 years. Proper pre-hospital evaluation and care can do much to minimize suffering, long-term disability, and death from trauma. Understanding the basic physical concepts that dictate how injuries occur and affect the human body will allow you to size up a crash scene and use that information as a vital part of patient assessment. Evaluation of the mechanism of injury for the trauma patient will provide you with an index of suspicion for different types of serious and/or life-threatening underlying injuries. The index of suspicion is your awareness and concern for potentially serious underlying and unseen injuries. Certain injury patterns occur with certain types of energy events. The amount of energy exchanged has a major role in the severity of injuries, along with anatomic structures potentially involved. Energy and trauma. Traumatic injury occurs when the body's tissues are exposed to energy levels beyond their tolerance. Mechanism of injury is the way in which traumatic injuries occur. Three concepts of energy are typically associated with injury: potential energy, kinetic energy, and the energy of work. Different forms of energy produce different kinds of trauma. Mechanical energy is energy from motion. Kinetic energy reflects the relationship between the mass of the object and the velocity at which it is traveling. Kinetic energy is equal to 1/2 times the mass times velocity squared. Potential energy is energy stored in an object, such as a brick sitting on a building ledge. Chemical energy is the energy released as a result of a chemical reaction and can be found in an explosive. Thermal energy is energy transferred from sources that are hotter than the body. Barometric energy can result from sudden and radical changes in pressure. Kinetic studies the relationships among speed, mass, direction of the force, and for advanced EMTs, the physical injury caused by speed, mass, and force. Mechanism of injury profiles. Different types of MOIs will produce many types of injuries. Injuries sustained by trauma patients may be the result of multi-system trauma, falls from heights, motor vehicle and motorcycle crashes, gunshot wounds, and stabbings. Maintain a high index of suspicion for serious unseen injuries. Table 26.1 lists significant MOIs. Blunt and penetrating trauma. Blunt trauma is the result of force to the body that causes injury, primarily without anything penetrating the soft tissues or internal organs and cavities. Penetrating trauma results in injury by objects that pierce and penetrate the surface of the body and injure the underlying soft tissues, internal organs, and body cavities. Either type of trauma may occur from a variety of MOIs. Blunt trauma. Results from an object making contact with the body. Motor vehicle crashes and falls are two of the most common MOIs for blunt trauma. Maintain a high index of suspicion during patient assessment for hidden internal injuries in patients with blunt trauma. Motor vehicle crashes, classified traditionally as frontal or head-on, rear end, lateral or T-bone, rollovers, and rotational or spins. Principal difference among these crash types is the direction of the force of impact. Three collisions occur in a typical impact: the collision of the vehicle against another vehicle, tree, or some other object, the collision of the passenger against the interior of the vehicle, and the collision of the passenger's internal organs against the solid structures of the body. Contre-coup injury: as the brain strikes the front of the skull, the body begins moving backwards. The head falls back against the headrest and/or seat, and the brain slams into the rear of the skull. Damage is produced to both the front and the rear of the brain. Your initial general impression of the patient and the evaluation of the MOI can help direct life-saving care. Severe deformity of the vehicle or intrusion into the vehicle correlates to significant MOI. Severe deformities of the frontal part of the vehicle, moderate intrusions from a lateral T-bone type of collision, severe damage from the rear, and crashes in which rotation is involved, which is rollovers or spins. Digital photos of the crash scene may provide valuable information to the staff and treating physicians of the trauma center. Photos should never be shared over social media. Patients should be assessed according to the area of the body that was most likely injured. Table 26.2 describes the structural clues, body clues, and resulting injuries for different types of crashes. Frontal crashes. Understanding the MOI after a frontal crash involves first evaluation of the supplemental restraint system. Determine whether the passenger was restrained by a full, properly applied three-point restraint. If the airbag did not inflate during the accident, it may deploy during extrication. Seatbelts may also cause unseen abdominal injuries, particularly in pediatric patients. Look for abrasions and/or traction-type injuries to the face, lower part of the neck, and chest. Supplemental restraint systems can also cause harm, whether they are used properly or improperly. Contact points are often obvious from a simple, quick evaluation of the interior of the vehicle. The knee can strike the dashboard, resulting in a hip fracture or dislocation. Serious chest and abdominal injuries can result from striking the steering wheel. Head and spinal injuries can result when the face and head strike the windshield. Ejection results in second impact injuries when the body comes in contact with the ground or objects outside the vehicle. A dangerous lung injury may occur if your patient takes a deep breath just before impact, hyperinflating the lungs and closing the glottis. The impact of the steering wheel can injure the lungs by generating pressures in the lungs beyond the capabilities of the lung tissue. Table 26.3 lists injury patterns, and Table 26.4 describes the ring of chest injuries that can occur from impact with the steering wheel or dashboard. Rear end crashes cause whiplash-type injuries. The cervical spine and surrounding areas may be injured. The patient may sustain an acceleration injury to the brain. Passengers in the back seat wearing only a lap belt might have a higher incidence of injuries to the thoracic and lumbar spine. With lateral crashes, lateral whiplash injury occurs. Patients could experience rotation of the neck, lateral flexion, or a combination of both. If there is substantial intrusion into the passenger compartment, suspect lateral chest and abdomen injuries on the side of impact. Rollover crashes. Injury patterns are difficult to predict. An unrestrained passenger may have sustained multiple strikes within the interior of the vehicle. The most common life-threatening event in a rollover is ejection or partial ejection of the passenger. Even when restrained, passengers can sustain severe injuries during a rollover crash. Rotational crashes. Injuries are the result of a combination of frontal and lateral impacts. Three-point seatbelts are effective in preventing injury and angled crashes of up to 45 degrees. Table 26.5 summarizes how to recognize developing problems in trauma patients. Vehicle versus pedestrian crashes. Three phases of impact: the vehicle and pedestrian impact occurs. The pedestrian rotates onto the hood, and then the pedestrian rolls off onto the ground. Injury pattern depends on the height of the pedestrian and the body area facing the impact. This often results in patients who have graphic and apparent injuries maintain a high index of suspicion for unseen injuries. Vehicle versus bicycle collision. Evaluate the MOI in much the same manner as vehicle versus pedestrian crashes. Additional evaluation of damage to and the position of the bicycle is warranted. Presume that the patient has sustained an injury in the spinal column or spinal cord until proven otherwise at the hospital. Motorcycle crashes. These are especially dangerous because the rider has nothing to help protect him or her except any protective devices that may be worn. Patients who have experienced a motorcycle crash should undergo cervical spine assessment and have cervical collars placed if indicated. Leather clothing protects mostly against road abrasions but offers no protection against blunt trauma from secondary impacts. Look for deformity of the motorcycle, the side of the most damaged, the distance of skid marks in the road, the deformity of stationary objects or other vehicles, and the extent and location of deformity in the helmet. 4 types of motorcycle impacts: head-on crash, is the forward and upward motion at the point of impact, causing the rider to go over the handlebars. If the rider's feet remain on the pegs or pedals, the forward and upward motion of the upper torso is restrained by the legs, producing bilateral femur or tibia fractures and severe foot injuries. Angular crash. The rider sustains direct crushing injuries to the lower extremity between the object and the motorcycle. Trapped legs may be fractured and or dislocated. Traumatic amputations are also common high-speed injuries. Ejection. Severe abrasion injuries, known as road rash, down to the bone, and an unpredictable combination of blunt injuries can occur. A controlled crash, known as laying the bike down, a technique used to separate the rider from the body of the motorcycle and the object to be hit. As a collision approaches, the motorcycle is turned flat and tipped sideways at 90 degrees to the direction of travel so that one leg is dropped to the grass or asphalt. This slows the occupant faster than the motorcycle, allowing for the rider to become separated from the motorcycle. A rider unable to clear the bike will continue into the vehicle, often with devastating results. In injuries from off-road vehicles, reaching the patient is often a challenge. Falls. The greater the height of the fall, the greater the potential for injury. Internal injuries are the least obvious on assessment but pose the gravest threat to life. Identify what type of surface the patient landed on and how he or she landed. Patients who fall and land on their feet may have less severe internal injuries because their legs may have absorbed much of the energy of the fall. They may have very serious injuries to the lower extremities and pelvic and spinal injuries. Take the following factors into account: the height of the fall, the type of the surface that was struck, the part of the body that hit first, followed by the path of energy displacement, in the area of the body over which the impact is distributed. Always consider syncope or other underlying medical causes of the fall. Penetrating trauma. This can be classified as low energy, medium energy, or high energy. Low energy penetrating trauma may be caused accidentally by impalement or intentionally by a knife, ice pick, or other weapon. Point-blank and high-velocity gunshot wounds result in more significant injuries. Angle or direction of travel is also pertinent. In gunshot wounds, the internal organs that are injured may have no relationship to the entrance wound and the exit wound. First, determine the number of penetrating injuries, then combine that information with what you know about the potential pathway. For gunshot wounds, the path the projectile takes is referred to as trajectory. Frangible bullets will increase damage as multiple fragments increase the likelihood of multiple organs or vessels sustaining injury. Hollow point bullets expand as they enter the target in order to decrease penetration and cause more tissue damage. Full metal jacket bullets cause less damage than fragmented rounds. The bullet speed is a major factor in the resulting injury pattern. Cavitation results from the rapid changes in tissue and fluid pressure that occur with the passage of the projectile. A temporary cavity is produced by stretching the tissue surrounding the point of impact. Permanent cavitation injury results closer to the bullet path where the pressure fluctuations are greatest and remains after the projectile has passed through the tissue. The relationship between distance and severity of injury varies depending on the type of weapon involved. Exit wounds are often much larger than entrance wounds. Organs injured in a gunshot wound vary depending on the pathway of the projectile. Blast injuries. Although most commonly associated with military conflict, blast injuries are also seen in civilian practice in industrial settings. More common today owing to the increased use of explosives as a tool for urban terrorism and in the United States from methamphetamine laboratory explosions. Although civilian explosions in an industrial or mining setting used to be mostly characterized by blast injuries and burns, terrorist bombs often contain shrapnel. Categories of blast injuries. Primary blast injury is entirely due to the blast itself. Damage to the body caused by the pressure wave generated by the explosion. Flash burns are also considered part of the primary injury pattern. Organs generally affected by primary blast effects are the lungs, eardrums, and other compressible structures. Proximity to the origin of the pressure wave is associated with a high risk of injury or death. So this image shows the mechanism of blast injuries. You have the primary blast injury, which is injury due to the blast wave itself. The secondary blast injury, these are injuries due to missiles being propelled by the blast force. Tertiary blast injury is injuries due to impact with another object, and quaternary blast injury, those are the injuries such as burns, crush injuries, and toxic inhalation. Alright, secondary blast injuries. These result from being struck by flying debris. Projectiles present serious hazards. Flying debris may cause blunt and penetrating injuries. With bombs, the casing fragments rip apart with monumental force, spreading in all directions. Nails, wood splinters, and glass shards can impale people located near the blast. Tertiary blast injuries. These occur when a person is hurled by the force of the explosion against stationary, rigid objects. The injuries that result are numerous and result from both blunt and penetrating mechanisms. Quaternary or miscellaneous blast injuries result from the miscellaneous events that occur during an explosion. Heat generated during an explosion may cause burns, ranging from superficial flash burns to full thickness burns. Quaternary blast injuries are caused by biological, chemical, or radioactive contaminants that have been added to a traditional explosive device. The initial explosion disperses these materials, causing additional long-term damage through biological, chemical, or radioactive mechanisms. Pay particular attention to the different blast injury zones, primary, secondary, tertiary, quaternary, and quinary, because this is registry based. I have seen and heard of multiple questions on National Registry that give you either specific injuries or will list the specific zone, and you have to pinpoint injuries. So this is National Registry material. Okay, tissues at risk. Organs that contain air are most susceptible to barotrauma. Tympanic membranes are a sensitive indicator that you can use to help determine the possible presence of other blast injuries. The patient may report ringing in the ears, pain in the ears, or some loss of hearing, and blood may be visible in the ear canal. Pulmonary blast injuries, pulmonary trauma that results from short-range exposure to the detonation of explosives. The primary blast injury is often characterized by a lack of external visible injuries. The patient may report tightness or pain in the chest and may cough up blood. Pneumothorax is a common injury and may require emergency decompression in the field by paramedics. Pulmonary edema may ensue rapidly. Arterial air embolism occurs on alveolar disruption with subsequent air embolization into the pulmonary vasculature. Solid organs are relatively protected from shock wave injury but may be injured by secondary missiles or a hurled body. Hollow organs may be injured by similar mechanisms, the same as lung tissue. Underwater explosions result in the most severe abdominal injuries, and neurologic injuries and head trauma are the most common causes of death from blast injuries. Multi-system trauma. This refers to the injuries of a person who has been subjected to multiple traumatic injuries involving more than one body system. Recognized patients who fit into this classification provide rapid treatment, transportation, and alert medical control. Multi-system trauma patients have high morbidity and mortality. The golden principles of pre-hospital trauma care. Ensure your safety, the safety of your crew and the patient. Determine the need for additional personnel or equipment. Evaluate the MOI and identify and appropriately manage life threats. Begin by assessing and managing the airway, including ventilatory support and high flow oxygen while maintaining cervical spine stabilization. Ensure that basic shock therapy is completed. After threats to the ABCs are corrected, rapidly proceed with spinal immobilization if indicated. During transport, obtain a sample history. For critically injured patients, consider paramedic intercept and/or air medical transportation. Patient assessment. Identify life-threatening illnesses and injuries as soon as possible to improve patient outcomes. Apply this knowledge as well as the appropriate assessment skills to assess, triage, treat, and transport patients with traumatic injuries to the most appropriate facility. Injuries to the head. When the head is injured from trauma, disability, and unseen injury to the brain may occur. Bleeding or swelling inside the skull from brain injury is often life-threatening. Neurologic assessments coupled with the patient's level of consciousness will often provide details on subtle changes in the patient's condition. Injuries to the neck and throat. Injuries may result in an airway problem that could quickly become a serious life threat. Your assessment must include frequent physical examination, looking for deformities, contusions, abrasions, punctures, penetrations, burns, tenderness, lacerations, swelling in the neck region. That's your DCAP BTLS. Swelling may prevent blood flow to the brain and cause injury to the central nervous system. Always use an occlusive dressing on any open neck wound. Either air in the circulation or an airway cartilage fracture may cause rapid death. Injuries to the chest. Blunt trauma to the chest can fracture ribs or the sternum. Depending on the severity of the trauma, the large vessels of the heart may be torn inside the chest and cause massive unseen bleeding. A pneumothorax, air collects between the lung tissue and the chest wall, compressing the lung tissue and interfering with the body's ability to effectively exchange oxygen. A tension pneumothorax, lung tissue becomes squeezed under pressure until the heart is also squeezed, preventing a return of venous blood and thereby reducing preload. Hemothorax, blood collects in the chest and causes interference with breathing. Regardless of the particular injury, it is imperative that you reassess a trauma patient's chest region every 5 minutes. Injuries to the abdomen. The solid organs may tear, lacerate, or fracture. This causes serious bleeding into the abdomen that can quickly cause death. When hollow organs are injured, they may rupture and leak toxic chemicals used for digestion into the abdomen. Healthy young adults are able to compensate longer than others for blood loss. Maintain a high index of suspicion when the MOI suggests injury to the abdominal region. This is accomplished by reassessing the abdominal region using DCAP BTLS. Management, transport, and destination. Have a good working knowledge of the resources available to you, including the most optimal methods of rapid transport in trauma centers. The trauma lethal triad. The trauma lethal triad of hypothermia, coagulopathy, and acidosis is a major contributor to death in patients with severe traumatic bleeding. Hypothermia contributes to coagulopathy. Any factor that interferes with blood clotting will cause more blood loss. Aggressively seek to control all bleeding to the best of your ability. Do not hesitate to use a tourniquet to stop bleeding from an extremity. Keep your patients warm. Ensure IV fluids are warm to at least normal body temperature. Minimize the volume of acidic IV fluid you administer to prevent interfering with coagulation and contributing to acidosis. Scene time. Limit on-scene time to the minimum amount necessary to correct life-threatening injuries and package the patient. On-scene time for critically injured patients should ideally be less than 10 minutes. Criteria to identify a critically injured patient is a dangerous MOI, decreased level of consciousness, and any threats to airway, breathing, or circulation. Type of transport. When making the decision to transport by ground, several factors should be taken into consideration. Can the appropriate facility be reached within a reasonable time frame by ground transport? Air transportation EMS units or critical care transport units are generally staffed by critical care transport professionals. Be familiar with your local protocols defining indications for use of air medical transport. The Association of Air Medical Transport Services, or AAMS, and MedEvac Foundation International identify the following criteria for the appropriate use of emergency air medical services for trauma patients. An extended period is required to assess or extricate a remote or trapped patient. Distance to the trauma center is greater than 20 to 25 miles. The patient needs medical care and stabilization at the advanced life support level. Traffic conditions or hospital availability make it unlikely that the patient will get to a trauma center via ground ambulance within the ideal time frame. There are multiple patients who will overwhelm resources at the trauma centers reachable by ground within the time frame. Air transport to mitigate the effects of delay caused by EMS systems that require patients to be brought to the nearest hospital for initial evaluation and stabilization, rather than bypassing those facilities and going directly to a trauma center. And also multiple casualty incidents. Destination selection. Before you even get to the scene, know the criteria for referral to a trauma center and what hospital resources are available in your area. It is important to transport your trauma patient to the most appropriate facility based on his or her injuries. Trauma centers are classified into levels 1 through 4. Level 1 has the most resources, followed by levels 2, 3, and 4 respectively. A level 1 facility is a regional resource center and generally serves large cities or heavily populated areas. Level 1 facilities must be capable of providing every aspect of trauma care from prevention through rehabilitation. A Level 2 facility is typically located in areas of lower population density. Level 2 centers are expected to provide initial definitive care regardless of injury severity. Level 3 facilities serve communities that do not have access to Level 1 or 2 facilities. Level 3 facilities provide assessment, resuscitation, emergency care, and stabilization. A Level 3 facility must have transfer agreements with a Level 1 or 2 trauma center. Level 4 facilities are typically found in remote, outlying areas where no higher level of care is available. These facilities provide advanced trauma life support prior to transfer to a higher level trauma center. Trauma centers are categorized as either adult trauma centers or pediatric trauma centers. You must be certain to transport your pediatric trauma patient to a pediatric trauma center if there is one in your area. It is important for you to be familiar with how the American College of Surgeons Committee on Trauma, the ACS COT, classifies trauma care. And that is it for Chapter 26, Trauma Overview.